I'm going to present on the 90-90-90, which women are left behind in Africa.
Green button, just push green button, this big green button.
Great. So this just gives an overview of HIV. This really are statistics that we're all familiar with. About 38 million people living with HIV, and of which just about 36 million are adults, 1.7 million children, and of all with HIV, 79% knowing their status. And the missing gap, the 8 million people who do not know their status. This, at the end of 2019, from UNAIDS statistics, really based on the 1990 cascade, does demonstrate that 62% of all people living with HIV were accessing treatment. And there they did break it down by categories. For adults, 62%, children, 54%, ages 0 to 14 years, 68% females 15 and older, and 55% for male. We do appreciate the discrepancies for both male and female in Africa, as much as the topic for today is centered around women. And high on the list of people knowing their status, 82% being pregnant women. In Africa, really, that is the gateway for testing. That is one of the biggest entry points, especially for women in the reproductive age groups. I'll skip this one. So what is it that we know? I'm not here to tell you anything new, but what we do know is that 42% of urban young women aged 15 to 24 have had sex and have had an HIV test. And 30% of rural young women aged 15 to 24 have done the same. But here, what we see here is the disparities based on location, whether you are a young woman who lives in urban versus rural. That said, the gap for the testing rate, it is still low and quite not acceptable. What else do we know? We do know that for incident infections, the vast majority are high among the young people aged 15 to 24 years. In some of the African settings, actually up to two-thirds of the incident infection are in the young between 15 and 34. And women have a disproportionately high rate of infection. And what we also see in terms of the prevalence, the men in Africa usually are lagging about 6 to 10 years, owing to the early sexual debut of women. What else do we know? We do know that female sex work or transactional sex does play a big role in terms of incident HIV infections. And this really puts our young women at a risk which is greater than 10 times that compared to the general population. For much of Africa, especially the southern Eastern Africa, we have been fortunate that over the last 6 years or so, most of the combination prevention trials have been focused in the sub-Saharan region. We do have data gaps, especially for women and young people in the West African belt. But in Southern Africa and Eastern Africa, because of these big trials, they have given us some insights in terms of what our epidemic looks like. Here of note, I'll just briefly go over the YATSI, which is the Botswana combination trial for which we participated. It was a community-based randomized trial, over 30 communities. It looked at a population of just about 108,000. And of that, here we looked at the study participants who qualified. About 29% of them were living with HIV, as documented at baseline. And of those who were living with HIV, 83% already knew their status. And of those who knew their status, the first 90, 87% were actually on ART. And of those who were on ART, they had a verifiable viral load of over 95%. Botswana was unique in the sense that it is one of the programs that had instituted viral load monitoring from the beginning of its national ART program. So really this set the baseline for follow-up over the next 3 years. And what we had appreciated also was the prevalence by age and sex. We do appreciate for the young, 16 to 24, 26 to 34, and 35 to 44, the prevalence has been consistently higher in the females. And you also see the time lag for prevalence by sex, with men almost catching up 10 years later. So really, it looked at intervention and standard of care communities. The intervention communities really, they had put a package that included testing, linkage to care, ART, and documentation of viral load suppression. What also spiraled how fast the study moved was the implementation of the Treat All in 2016, as Botswana was one of the first. But what we do appreciate there was that looking at the female predisposition, the females still had disproportionately high rates, incident rates. And looking at the age group, the more vulnerable, the 16 to the 34-year band compared to the males. So what did this study show in terms of knowledge on HIV? We do appreciate at baseline and end of the study for females age 16 to 24, we had an increase of about 73%. But interestingly also, we even had higher increase for males. What we had appreciated in the study is that as much as females were disproportionately affected, the males, when tested, they accepted, and when they were offered ART, they did equally as good as the women. So this is just an excerpt from the South African policy brief from December 2016, just demonstrating for them where the challenges were. It was appreciated that indeed testing had improved, but also it had demonstrated that men lagged behind. But it did acknowledge that about 3/4 of the new infections were in youth, disproportionately high in females. For the second 90, it also acknowledged the same in terms of who is on ART. We still see that 60% more was women and 43 male. But we also appreciated that in terms of access, more than 80% of age 15 to 19 years had access treatment. For the purpose of this talk, really, we worry about those gaps that we need to address in terms of this younger population group. And also demonstrated for retention, for the various reasons. The 15 to 19-year-olds, it was a turbulent time. They had lower retention rate, also had lower viral suppression rates. So what does this really say? It says to us that what we are looking for in terms of the gaps for the 1990 and the interventions that should take place, they really need to be targeted. It does give us that sense that we really need to be targeting rural women more than the urban. All women, all young women, ages of 16 to 35, and we do see that particularly the younger, especially after sexual debut, the 16 to 24-year band, and the female or transactional workers. A lot of this fueled by issues of poverty in our communities. So really for these young people, what is it that drives these new infections? Inconsistent condom use, age or transgenerational sex, transactional sex, multiple concurrent sexual partners, really, and limited access to sexual and reproductive health information and youth-friendly services. A lot of this also influenced by some of our cultural barriers in terms of acceptance that young people are sexually active, in terms of our policy barriers by age, who should access these services, whether family planning, whether testing, because for a lot of the African countries, it has been around the age of 16. And of course, issues are around gender-based violence. So there definitely is a need for targeted interventions. Unfortunately, for a lot of the southern Eastern African countries, which are PEPFAR funded, there has been a lot of emphasis on this for these targeted interventions, offer of PrEP and self-testing in young women, youth-friendly services, really outside the traditional clinical setting, and this should be out there in the community and driven by the community and youth. The health system has not been able to respond to some of the challenges of adolescence because we are very clinical. Issues of economic stability. A lot of young women come from rural and poor backgrounds. Hence, the need to address that. It has been a big issue from a political standpoint in many countries, but we have seen some programs like in South Africa, when they offered economic incentives, these young women actually did better on ART. There will always be issues of gender inequality, definitely a need for behavioral change, interventions, and other prevention initiatives. So really, just in closing, I think for the large part in Africa, women have done better in terms of access, but it's just the disproportionately high rates of HIV infection. And just my acknowledgement slides from some of the sources and the help I got. Thank you.
Thank you, Tendani.